Good evening. People in disasters. It's something we know too much about in Christchurch, don't we? And so too does Mike Ada, a professor of emergency medicine. He is my guest tonight, and Lynched starts right now. Good evening, thank you for your company tonight. The People in Disasters Conference that'll be held at the Air Force Museum early next year. And while the title might not sound all that appealing, the location of Christchurch is the perfect place to hold such a conference, don't you think? It's a joint venture between the Canterbury District Health Board and Researching the Health Implications of Seismic Events Group, which was established after the Canterbury earthquakes. Mike Ada, a professor of emergency medicine, is the co-convener, and he joins me tonight on the program, and it's great to have you on the program.
Hello, Chris.
First of all, let me ask you about this group with the very long title. What do you do in terms of the research that you've been doing following the earthquakes? Because I think that's quite interesting.
It's been fascinating, actually. So the RISE group, as you say, researching the health implications of seismic events, and inevitably the acronym is slightly contrived. We've got an H in it for the health part of it.
Yes, I wasn't sure how to start, so I just left it out. Went for the whole lot.
Went for the whole lot. So RISE. We set this up after the 2011 earthquakes in Canterbury, for a few reasons, but mostly to facilitate research. So it's a very large group of nearly 200 people, 200 different researchers who joined together in a web-based format for communication and collaboration. And the idea was to facilitate research so that we could tell the stories of what happened to us, understand them better, and also own the research to a degree, because there is a history with natural disasters that very often very well-established disaster research centres, of which there are a number around the world, they sort of swoop in and grab the data and tell the stories on our behalf, and we didn't want that to happen. We wanted to own this event and learn from it ourselves.
So it must be quite important to have all those professionals all contributing to one database as to what they were experiencing during their time with the disaster.
Absolutely, there's lots going on. I mean, we can't claim ownership. We certainly provide the forum for collaboration, but there's many researchers doing a lot of work, particularly in the field of psychology and mental health, which will be a theme of this conference. But there's a lot of other work going on as well. I'm an emergency medicine specialist working in the emergency department, so my interest is in people who get injured, so I'm interested in the physical stuff. But certainly the psychological part of the learning of the story is a very big one that's part of our brief.
Mike, it seems to me, from what I've seen, the research I've seen, that the emergency department staff at Christchurch Hospital and other centres throughout Canterbury did an extraordinary job, not only dealing with the carnage, but also they too were dealing with the trauma. And I guess that's interesting in itself, isn't it? Because that's different to any other disaster that we may face across the globe, because they too were actively involved in it. Yeah,
that's absolutely right. And that's, again, one of the reasons we need to tell the story. Our situation is, in fact, unique. It's not just unusual, but it's unique in the nature of the health system and the fact that we've only got the one acute hospital that has an emergency department and so on, and the fact that we were both victims and responders. And you're absolutely right, the stories that people tell. One of my colleagues, Sandy Richardson's a nurse who's interviewed many of the staff, and it's extraordinary the sort of the turmoil in their heads and their hearts as they were doing the job they were doing. And it's a very interesting thing. I mean, we do want to relive it, but we certainly want to learn from it, I think. And to a large degree, I remember, and my apologies if this is going slightly beyond the censorship rating of this show, but I remember talking to one of the doctors in our tea room after the earthquake, and we were relatively quiet in the days there afterwards. And I said to him, why do you come to work when we're relatively quiet and you're not needed on the roster? And he said, it gives me something to do, and anyway, I can have a shower and a shit. Because of course there was no running water or any of that sort of stuff back in his place. So it was actually quite therapeutic for us to be able to focus on a job at hand, a job that needed to be done. And we just knew, a lot of people I think in a disaster situation, they're thinking, what do I do now? You know, what is it that I'm supposed to do in this circumstance?
But also, I suppose, it gives them something else to do, as opposed to worrying about their house that may have collapsed.
Yeah, yeah.
They're actually at work doing something else, even though in an odd way that was probably related to the earthquakes.
Yes, yes. And some of the stories are extraordinary. We had doctors and nurses who came to work religiously, even though they were displaced, some of them hundreds of miles, you know, up into Castle Hill and all sorts of places. They'd turn up for work religiously. The dedication and the commitment to the job, I think, was fantastic.
Do you think part of the reason why they turn up to work every day, because it's in their blood, excuse the horrible pun, but because that's what they're trained to do, but I guess they would never get a sense that they'll be dealing with, you know, one of New Zealand's, if not New Zealand's biggest natural disaster. So they go into, in a way, work mode in every sense of the word, if you know what I mean.
Yeah. I mean, you're absolutely right. I mean, for us in the emergency department, and we were just a small, as you alluded to this before, we're just a small part of a very big cog, which worked extremely well together, and that's part of the success, I think. But in the emergency department, in a sense, the events of February the 22nd, 2011 were nothing new, but they were entirely new. So all the components we'd met before, we'd met lots of patients, we'd met trauma, we'd met you know, various emotional distress and loss and all these sorts of things, but not all at once in quite that amount. And then
that's what I was going to ask you, Mike, because although the staff, no doubt former colleagues and current colleagues of you now, although they're trained to deal with trauma and emergency situations, I suppose in the way, how do you prepare emergency staff for an earthquake? Although I know that we live near a fault line, but I bet nobody suspected what actually would happen though, or was there training before that though?
Yes,
I mean, how do you prepare for something where you don't know the fault line exists in the first place?
Yeah. One of my senior colleagues who didn't work in the emergency department but was working elsewhere and did a fantastic job during the earthquake was quoted by local media. When he was interviewed, he said, how did the plan go? He said, there wasn't any plan. We just used our common sense. There was a plan, and that's testament to how good the plan is, the fact that someone who didn't know about the plan could fit in very well. We practiced it a lot. It was a very well contrived plan. We'd practiced it previously. We'd actually run the disaster plan in the hospital a couple of times for real, with a bus crash and a train crash and various other bits and pieces. And we practiced it regularly. We'd practiced it in a virtual disaster format just some months earlier, before the September 2010 quake earlier that year. And so we did practice from time to time, and when we put into action, it mostly worked. There's a few changes we've made since, but it worked quite well. And I think we were, clearly this is an event none of us want to repeat, but there is an element of pride in terms of how we got through it, that things came together well.
Are you proud of the staff?
Very much so, yeah, very much so. I think there's the leadership, the followship, which is a crucial part of leadership. It makes it work. The structure and the context in which we worked. And if you look at a disaster plan or a mass casualty incident plan or a major hazard event, you know, you've got layers of hierarchy of control and planning all the way up to the Ministry of Health, of course, and so on. And all of these worked well. So in the emergency department, in the hospital, in the district health board and beyond, they worked well together.
We're going to take a break, but when we return, I do want to discuss the Christchurch response in terms of the context internationally and where we fit into this internationally, especially when it comes to that conference. So plenty more to come as the show continues. Welcome back to Lynched on CTV. My guest tonight is Professor Mike Adair. Mike, in terms of the Christchurch response to the earthquakes and in terms of this conference that you are helping to organise early next year for health professionals and anybody interested in people and disasters, it is called People in Disasters, I note, you want to explore or look at the Christchurch response in an international context. Now, why is that? Because I would have thought that each natural disaster has its own implications, has its own troubles, has its own challenges. But why is that important to look at the Christchurch earthquake internationally?
Yeah, for two reasons. For both learners and teachers, we've learned a lot from our disaster, and we've done a lot, and we know our story reasonably well. We're learning more about it as we examine things more closely.
When you say we've learned a lot, what do you mean by that?
About how we coped, about how the health system coped, about how we as people and our structures and the plan that we practiced and contrived earlier, how that came together, the things that might be done differently. And so we've learned a lot about that sort of stuff, and we've also learned much more, and some of my colleagues who will be helping us with the conference and presenting at the conference can talk much more about the subsequent stages of a disaster, which we're still going through, of course. I mean, we know we had a 6.3 or 6.2 or whatever it was Richter scale, but we need a new scale for the traumas of the disaster that go on for the years. Call it the Lynched scale, if you like. A Lynched 9.5, we might grade it after 5 years of the troubles that people have to get back to where they were before. So we're learning a lot about that now, and my colleagues are looking into that in some depth, particularly the issues of resilience and mental health, trauma, stress, and so on that we're going through. But a lot of that, there's been an awful lot written about disasters by researchers and academics, but we don't know a lot about it because clearly disasters are such where you can't do a lot of planned research. They just turn up and then you look at them. And so the more disasters we have, the more we learn and the more we can sort of extrapolate and triangulate and learn things. For example, our disaster is unique, as I alluded to earlier, in the sense that we are a first world health system with a city which has high standards in all regards, building standards, health standards, all of these things. Yet it's a disaster where the health system was part of the disaster. It was one of the casualties and had to respond. And we have a single acute hospital with an emergency department, intensive care unit and operating theatres, which was part of this disaster. It was compromised. And that's a unique story. If you go to other first world disasters like Kobe in Japan or some of the Californian earthquakes and so on, that's not the same. They've got a much more complex health system with people all over the place and hospitals all over the place that can chip in or close down or whatever they do.
So in a way, Mike, were we actually fortunate that, not fortunate is not the right word, but to have the one-stop shop that we've got now, being mainly Christchurch Public Hospital, where you've got all your facilities largely based in one premise? Did that make Christchurch better off following the earthquakes, as opposed to, as you say, multiple facilities as some international cities currently have? Yeah,
we've got a very, I think in part, I mean obviously that's a sort of an eggs in one basket scenario to a degree, although our colleagues throughout the system, including our primary care colleagues, the GPs, the after hour surgery and Belly Ave, did an incredible job as well. But yes, and I think not so much that we've got a single acute hospital, but we've actually got a very linked up system in Canterbury, and that's a feature of the Canterbury District Health Board and the Canterbury Health System, which predates the earthquake. You go back to the flu pandemic, the swine flu and all that sort of stuff.
H5N1, thank you very much.
All that sort of stuff, yes. And the work that we did as a joined up health system to battle that. So, and this has been celebrated both before the earthquakes and since. In the international literature and international forums.
I don't think many people realise too that when there is the sense of SARS or bird flu, what have you, that New Zealand has a very robust pandemic action plan that's put into place at every major hospital in this country, where you do have pretty robust action plans to make sure if a pandemic hits Christchurch, we're well covered.
Yep. So being a little bit smaller is actually quite useful because it means we do have these links. But Canterbury in particular, I mean, I don't wish to continually blow the Canterbury trumpet, but
you can on this program, Mike. It's fine.
But it is. There's been a lot of work in this regard, and Phil Schroeder, who is the GP out at Ralston, but he chairs or directs or whatever the term is. He leads the primary care part of the disaster response or the emergency response. It kicked in and was very involved in the flu stuff earlier on, and again in the earthquakes, and subsequently he's presenting at the conference as well to talk about that, because what our primary care people do is unique. Again, it's world leading in many respects. So obviously a general practice you might imagine is a standalone business that does stuff and may interact with other bits and pieces as required. But we've got a very joined up system here in Canterbury, and that helped us a lot.
In terms of the good stuff that has come out from the CDHP, I mean, I know recently they won various top awards recognised nationally. Does it surprise you then that, in a sense, you've got the ministry trying to almost have its mitts on what's happening in the hospital system, given that we have experienced a major earthquake, given that rebuilds are still underway, insurance issues, and the fact that by and large it hasn't done that bad a job? Does it surprise you we've got a ministry that's looking down and seeing what's going on?
Yes, it does. It's fascinating actually. I mean, if I wasn't one of the lab rats in the middle of it all, I'd find it a really interesting thing from a scientific perspective to examine all of this. But we've got a couple of things going on. We've got a system that was working towards integration, particularly hospital and community services joined up so that they knew what each other were doing. And there's lots of examples of how that was manifest. And getting more people back to their homes where they're healthier and happier. So that was a philosophy that predated the earthquake. It's been accelerated massively since the earthquake times and was very successful. In fact, it's not only successful because of the philosophy of that being a good thing for people, but it's also very cost effective because hospitals are expensive places to be in.
And was that part of the award that the CDHB won? It
was part of the award that the CDHB won. So that's been accelerated post-earthquake. So we're doing very well. If we hadn't been doing that when the earthquake hit, first of all, we wouldn't have responded as we did on the earthquake day. So that's the first thing. And secondly, we would be in dire straits now. Now, one of the problems post-earthquake, and there are others who can speak more insightfully on this than I can, but the population and demand in Christchurch is just crazy. It's weird. It's odd. Now, demand for acute care, which acute care being emergencies and unexpected illness, you might think is pretty odd anyway, but in fact it's quite predictable. We know how many people are going to get sick on it, give or take. But it's become much less predictable in Christchurch, and there's an enormous mental health burden that we're carrying, that the DHB is dealing with. And I think we appreciate this, of course, because we're in amongst it, and we're suffering from it, and we're trying to deal with it. But I think when you use mathematical models to work out how many dollars should pay for how many healthcare units for people, sometimes it doesn't take this into account because, of course, this has never happened before. So the post-earthquake Christchurch is not a health system that a budget has been designed for to
Well, that's
date.
part of the problem. It should, shouldn't it?
It should.
You can't possibly do a financial review of a situation that's not normal.
Correct, absolutely. So there is a tendency, I think, and again, I'm a naive observer, so people can critique as they like, but the way I perceive things is that we've got a very unusual situation trying to be squeezed into a bureaucratic box, which is normal, a normal box for normal funding circumstances.
But as you say, this isn't normal. We need to take a break, but when we return, I do want to discuss a report that you were involved in. It seems like you were involved in all these reports when they come out, drunks and ED, and it's still a problem, fair to say, right? So we'll discuss that when we return. Stay with us. Welcome back to Lynched on CTV. My guest tonight is Professor Mike Adar, and this is his hat he's wearing on tonight because you sometimes work in the emergency department at the hospital as a doctor, as a physician, and you wear about 20 million different hats, but we'll call you Professor tonight. Is that all right?
That's fine. Yes, I'm very happy with it.
I want to just come back to this People in Disasters conference next year. It does sound like it is incredibly important. It's more than just a talk fest. You've got some incredible speakers that I want you to talk about as well. If people are considering coming to this, here's your chance.
Yes, indeed.
Give us your top two. No pressure, Mike.
Oh, the top two. It's very hard to.
Maybe I shouldn't say that because you've got four there.
We've got four fantastic international keynote speakers that we've been very lucky to attract, but we've actually got about a dozen other tremendous guest speakers, and probably dozens more speakers who are submitting abstracts to try and come along. In fact, we've got abstracts being submitted from all over the world for people to come and present. But I'll start with the keynotes, and you can stop me when you're sick of me. But Sir John Holmes is a fantastic political figure, a diplomat from the UK, who's with us. He's done lots of things. He's lived in many cities, Lisbon, Paris, New York, and now he wants to come to Christchurch, the highlight of his professional career. And he's got to present to us his experience in the UN when he was chair of, in fact, Under Secretary, I think it's called, of the Humanitarian Aid Division of the UN.
Right.
And how the international community works through the various political and other social barriers to deliver aid to people in trouble, whether it be from natural disaster or from man-made disaster. And he's got some fascinating stories. He's the author of a book called The Politics of Humanity. If you get a chance to read it, it's very, very insightful into the difficulties.
Sounds frustrating.
Very frustrating. It proves that people are wonderful, but they're also stupid. And getting aid through the sensitivities and the political barriers sometimes is difficult.
I can imagine.
So he's got the international perspective. That'll be balanced by the local perspective, both local, regional, Pacific and Asia Pacific, but also Christchurch and New Zealand perspectives. We've got a few other interesting people. We've got Jean LeBlanc there is a psychologist from Canada, and she's one of our keynote speakers, and she works for the Canadian CMAT, it's called Canadian Medical Assistance Team, and she's a psychologist, and the medical assistance teams are teams that go out from a country or a region to assist in disasters in other regions. We've formed our own NZMAT, New Zealand Medical Assistance Team, since the earthquake in Christchurch, and largely as a consequence of that earthquake. Some people in Christchurch will remember we had the Queensland MAT, the AusMAT team,
right, yeah.
who actually came to Christchurch. They're part of the whole scene, and of course they come to deliver medical aid in situations where aid is difficult. And Jean LeBlanc is a psychologist. She in fact delivers psychological aid to the injured, so psychological first aid, if you like. She's going to talk about that.
Wow.
We've got Sandy McFarlane from Adelaide, who's an expert on post-traumatic stress disorder, and particularly in relation to the military and veterans, and also first responders in disaster situations. And Davidson, Jonathan Davidson from Duke University in North Carolina, and he's in fact an expert also, a psychiatrist, an expert in psychological trauma, post-events, but also has his name attached to a resilience scale, so measuring people's resilience.
Sounds like you've got the best of the best, and I guess in a way you probably find a lot of the staff that you work with now have a greater interest in this because they've been through it themselves.
Yes, indeed.
Just want to briefly touch on ED before we're almost out of time. And I was interested, Mike, a study that was out last year that you were involved in, and it was in the medical journal, and I quote, maybe these are not your words, this might be the medical journal's words, "Horrendously drunk men, and to a lesser extent women, are placing a significant burden on the emergency departments, especially on a Saturday night." Now, when I was a young journalist, I interviewed you about this very problem about nearly 10 years ago now. It seems like nothing's changed.
No, you're still...
And nothing's still changed.
You're still a young journalist.
That's very kind of you to say that.
But the things are very similar. So alcohol, I mean, this is not news, as you well know, but
But nothing's changing, though.
Remains important. Yeah, and we're advocates for change. The reason we did the study that you've just mentioned is that we were trying to get a local alcohol plan revision, snapshot of what goes on in the ED. And the intention was that we'd repeat it the following summer. So that was done in the summer of 13-14. And so we're supposed to be doing it again since then, which we haven't, of course, because the local alcohol plans haven't yet been finalised. But the thought was that we would be able to prove that restrictions to access, just putting it that simply, that if you limit access to alcohol, then you will get less effects of alcohol coming in through our front door.
Well, that's common sense, isn't it?
And we believe that is the case. So we believe that's the case. In fact, there is evidence to suggest that that's the case from elsewhere in New Zealand and overseas. But
just finally, and what I find interesting too is that only today RNZ was reporting that emergency departments are starting to squeak, as in their, the increase of admissions is going up and all the time in Wellington, Auckland, and of course Christchurch, and the stress on staff is tremendous. Once again, you could argue this is nothing new, but it does seem to be getting worse. What do you put that down to? Is that the question you wish you knew the answer to?
It's one of the questions. It's multifactorial. I mean, it is actually very complex. We've been examining this for years, and we've been dealing with years of increased demand on the acute services generally, not just emergency departments. And there's all sorts of theories, and all of them are true, but none of them are true. So it's not one. It's all of the above. It's not people going there instead of the GPs, certainly not in Christchurch.
Well, that's good to know. I was going to ask you that. That's good.
But there is an element of that. There's an element of that. We want more people to go to their GPs without question. We want more people to be enrolled, but that won't solve the problem, because most of the people who are turning up in our place actually need to be there, and they need the care. It's an ageing population, but it's not just an ageing population. In Christchurch, it's a rebuild population, but it's not just that. So there's all sorts of aspects to it, but and of course we've had the flu quite.
Yes, and thank goodness. Well, hopefully, touch wood, we're coming out at the end of that. We're out of time, Professor Mike Adair. Nice to see you. Thanks for coming in. Fascinating. I'll talk to you for a lot longer. And just to let you know, folks, if you're interested in this disaster conference, it is peopleindisasters.org.nz. Well, thank you so much for joining me tonight. Don't forget, Christchurch Mayor Leanne Dalzell joins me for the weekly catch-up tomorrow on News Talk ZB. But from all of us here at CTV News, thanks for watching.